Hello everyone and welcome to the Improvement and Innovation Showcase 2024 from the Commission on Excellence in Innovation and Health, or the CIH for short. Welcome to the 13th series, which is all themed around environmental sustainability in healthcare. My name is Tina Harden and I'm the Executive Director of Clinical Informatics and Innovation at the CIH. I would like to start by acknowledging that the land that I'm on today is the traditional lands for the Kaurna people and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region and that their cultural and heritage beliefs are still as important to the living Kaurna people today. The dreaming is still living from the past, in the present, into the future, forever. I'd also like to acknowledge other lands that people may be joining us on for this session today as well. A little bit of housekeeping before we get right into the really exciting and interesting content and I get out of your way. The chat is turned off and your microphones are also turned off for the duration of the presentation, but you can start to feel welcome by adding in any questions or thoughts that you have into the Q&A tab at the top of your screen. We will publish the presentations. They're being recorded and they'll be published online as soon as we can. But this Q&A component of the session today, which will happen in the latter part, will not be recorded and published. At the end of the presentations, there will be a quick poll, which we strongly encourage you to do because that will really help us strengthen and make sure the content that we provide are relevant to you into the future for future improvement and innovation series. When we get to the Q&A section as well, we also will strongly encourage you to turn your mics on and turn your cameras on because we would love to see you and it makes it much easier for us to connect with you and see how we're travelling. For those that are not familiar with the CIH, hopefully now just about everyone is, but we're a lead agency in South Australia for innovation in healthcare, and we love bringing together a diverse group of people and perspectives from all across the health sector, including consumers, clinicians and other collaborators to turn ideas into better healthcare. Our vision is together creating health and prosperity for all. And we find it really, hence the poll component of this, where it's really important that we measure what we do because, we can't change what we don't understand. So that is really the essence about why we have the Improvement and Innovation Showcase series. It's about bringing people together, connecting them, sharing ideas, learning from each other, and really valuing those diverse perspectives. So what if the big idea was connecting the small ideas? The Improvement and Innovation Showcase is really a series of connected themed sessions, about 40 minutes and available online anytime. So if you think there's something interesting for one of your colleagues in today's presentation, please let them know that it'll be available through our CIH website and online through our YouTube channel. We aim to keep them simple and to be able to share and make the content really accessible to a broad range of stakeholders. And it's really about what's happening in your journey, your healthcare improvement and innovation journey, and at any stage, regardless of the level of success. We're really interested in being able to learn from each other and make sure we're building a stronger healthcare community for everyone. We focus on South Australia, but every now and then we're keen to share our showcase and insights with other jurisdictions and even globally to ignite ideas. If you've got a story to tell or a problem or have had success, please get in touch with us, cih@sa.gov.au. We are really keen to these series and as we said, share and collaborate. And so, we're open to any thoughts or ideas about what would make an exciting improvement and innovation showcase series. So please feel very welcome to get in contact with us. I now have the absolute honour and privilege of introducing our host for the series today and one of our speakers, from a previous session, Dr. Kimberly Humphrey. So Kimberly, over to you.
Thanks so much, Tina. Just wonderful. Delighted to be here again for this great series on environmental sustainability in healthcare. So as per a strategic direction, the CAH recognises the importance of addressing environmental sustainability in all facets of healthcare to reduce system impact on climate change and identify opportunities to adapt to its impact. So one of the things we really keenly want to do with this series is really show how this is relevant to everybody who's working in health, to kind of get out of the silo of climate change and show that this is integrated into practice across whatever you do, and it needs to be central to the work we do. For Series 13, the CEAH and the SA Health Climate Change Executive Governance Group, which we affectionately call CCEG, have collaborated to deliver a webinar series aimed at shining a spotlight on environmental sustainability in healthcare. So the CCEG itself is an executive governance group that sits across the Department for Health and provides kind of high-level advice and action on climate change. The series has been put together in anticipation of the launch, we hope in the next few months, of the SA Health Climate Change Framework, which is currently out for public consultation. This is the QR code. We are still accepting feedback on this, which will be used to revise and put forward a final strategy, final framework in the next month or two, which is really quite exciting. This will serve as our high-level roadmap for what we need to do for SA Health in the climate change space, both adapting and reducing our carbon emissions. Okay, so throughout the series, we will hear from a range of speakers who will share their insight on work happening across the sector, from ways to build climate resilient health systems to innovative decarbonising initiatives. If you haven't registered for the last session in the series, we invite you to do so via the QR code at the bottom left corner on your screen, which will link you to our event registration page. And we'll also post a link to the chat after the Q&A. We hope these sessions will inspire and equip you to consider how you can be agents for positive change in your respective jurisdictions. We now have the absolute pleasure of introducing our speakers for today on our topic of waste reduction in healthcare. So firstly, I'm going to introduce Sarah Ripley, who's a registered nurse. With over 12 years of clinical experience, Sarah transitioned into the crucial work of decarbonising healthcare, emphasising a dual focus on both patient care and planetary health. Sarah was the first sustainability officer within the South Australian Healthcare Network, and in this role, she spearheaded the development and the implementation of innovative sustainability initiatives, setting a precedent for environmentally conscious healthcare practices. Currently serving as a Sustainable Healthcare Manager for the Climate and Health Alliance, her primary focus work revolves around supporting the health sector to cut emissions, reduce its ecological footprint, and build climate health resilience. Thank you, Sarah. Next, it's my pleasure to introduce Chris Barber, who has a science background in medical research, having worked in both laboratory and evidence-based research environments in the public and private sector. With more than 15 years in the public health system, Chris has been part of several major projects in SA, including commissioning the RA and decommissioning the old RA. Her project management experience has included regional service delivery and strategy development, in addition to working in metro and peri-urban LHNs. At the Women's and Children's Health Network, Chris leads the Environmental Stewardship Committee and developed the Organisational Governance and Environmental Sustainability Framework for WCHN and the inaugural WCHN Sustainability Report 2023. Chris is the Manager of Corporate Operations at WCHN. And finally, I will introduce Christine Warneford, who is a registered nurse with over 16 years of clinical and leadership experience and is a clinical advisor on the new Women's and Children's Hospital project. Christine's current role as the Equipment Advanced Nurse Manager includes coordinating equipment and consumables procurement and trials within the surgical division. Her role is also an integral part of the perioperative leadership team. Christine is a committee member of the WCH Environmental Steering Committee and the founder and chair of the Surgical Services Recycling Working Group. Christine has a passion in achieving optimal best patient outcomes through equipment and consumable procurement and a sustainability focus. It is now my pleasure to hand over to Sarah to begin today's session. Thank you so much.
Thank you for having me. My name's Sarah Ripley. I'm a registered nurse and the Sustainable Healthcare Manager for the Climate and Health Alliance. The Climate and Health Alliance, or CAHA, is Australia's peak body on climate and health. CAHA is a coalition of 100+ health and medical groups, academic and research institutions, healthcare service providers and unions. CAHA has a long history of supporting more sustainable and resilient healthcare sector by coordinating global green healthy hospitals in the Pacific region for more than 12 years. I work to deliver the Global Green Healthy Hospital program and the new waste community of practice across the Pacific region. Today, I'm going to share what I've learnt working as a sustainability officer in SA about healthcare waste management. Just a brief overview of what I'll cover in the next 15 minutes. We will be looking briefly at the South Australian healthcare waste streams, discussing the health and environmental impacts of them, looking at waste management practices and examples of good practice, and then I'll hand over to the fabulous Women's and Children's team. Firstly, I wanted to start by saying that these aren't all the waste streams within our network, but I did want to show you the traditional waste streams you would see in the clinical setting, specifically in what we call our utility rooms, so not in the tea rooms or the office spaces. And as part of our commitment to sustainability and reducing its environmental impacts, we really do need to understand the composition of the waste that's generated within SA Health. So I'll just quickly run through the bins. So the red lidded bin is a general waste bin. Examples which would fill a general waste bin would be things like gowns, masks, gloves, sick bags, blue sheets, rigid medical plastic, soft plastic, and expanded polystyrene. Of the total amount waste that's generated by healthcare activities, 75 to 80% is general waste, and that is comparable to domestic waste. The brown lidded bins, the dry waste bins, are new to some healthcare facilities. Dry waste streams will take all types of plastic and paper clean materials that aren't wet. We have cardboard and paper bins, which is well obvious. Paper and cardboard materials are accepted. Hazardous waste is categorised on the basis of risk of infection and injury during its management and disposal process. These categories include sharps, so things like blades and contaminated needles, infectious waste, so blood and body fluid, and pathological waste, microbiological cultures and blood samples. And there are also hazardous waste streams that aren't pictured in these images, and they're usually called for specific treatments such as cytotoxic waste, so waste containing drugs for cancer treatment, chemical waste and radioactive waste. And the remaining 10 to 25% of our waste stream is this group that's considered hazardous waste. This slide shows the pathway of our waste from what's generated and where it ends up, images of our and what our waste may look like along the way, health impacts of contact, both direct from physical exposure to indirect through chemicals and emissions, and I'll talk to the main health and environmental impacts of what we generate. So firstly, landfill is an engineered in-ground facility for the safe and secure disposal of our waste. General waste, which is not recycled or reused and does not pose a threat or risk to public health or safety, meets the landfill criteria. Landfill gas is produced in landfill as waste decomposes and predominantly consists of methane and carbon dioxide, as well as containing a range of trace gases. Methane is the most powerful greenhouse gas over a 20-year period. It is 80 times more potent at warming than carbon dioxide and causes 1 million premature deaths every year. Then we move into our commingling and dry waste streams that go off to an alternate fuel factory. So process engineered fuel, known as PEF, is plastic waste that is processed with other waste material ready for direct use as fuel in high energy facilities such as cement kilns. According to the Health and Plastics Recycling Council, it is estimated that 1/4 of hospital waste in the United States is composed of plastic packaging and products, and 85% of waste is non-hazardous and therefore easily recyclable. For us, that percentage goes through this process. Waste to energy processing has many benefits. However, there are some disadvantages, such as the pollution and particles it generates, the destruction of useful materials, and the potential to disincentivise more sustainable waste management solutions and renewable energy sources. And finally, hazardous and sharps waste. In SA, medical waste must be destroyed in an incinerator. Waste incinerators are a type of waste-to-energy facilities which burns waste at very high temperatures, turning it into gas and ash. Medical waste has been identified as the third largest known source of dioxin emission and contributes 10% of total mercury emissions to the environment. Research shows us that 73% of incinerated waste doesn't even meet the federal guidelines. In the past few years, the generation of medical waste has significantly increased, and we saw that in the COVID-19 pandemic. Incineration is not the termination of plastic waste, and bottom ash is a potential source of microplastics released into the environment. Every year, the world generates 381 million tonnes of plastic waste, which is set to double by 2034. And we don't yet understand the health impacts of plastic, but we know that they are in us. I thought that the worst thing in my life was to swallow a spider in my sleep, and it turns out I'll eat almost 20 kilograms of plastic in my lifetime, and that is horrific. While this information can be really overwhelming, it's really important to understand the health and environmental impacts of our waste from health so that we can create ways to improve these practices and decrease the downstream effects that they have. And I do have good news. What we know is that healthcare institutes around this country are working on better waste management practices. Case studies demonstrate that small changes in workplace practices can result in significant reductions in waste and carbon emissions across the healthcare sector, often resulting in financial savings that can be reinvested in healthcare. So not only do we have the dual purpose of people and planet, we can save money along the way. I just wanted to show you these three images. The first one in the middle is a trolley that holds waste generated from a laparoscopic procedure. I think it was an appendix. One of our key green champions was in the theatre and managed the case. And through proper segregation and management, we saw, so that clear yellow bag off to the side goes off to the dry waste stream. The small plastic bag hanging on the side there, that's going to head to landfill. And then the yellow and red tub down the bottom, that holds irrigation, so body fluids and sharps, and that will head off to incineration. And the outer two photos, myself and a friend post a caesarean section, again with careful segregation was able to divert waste from landfill and incineration. Operating rooms generate as much as a third of all hospital waste, and we know that one of the most crucial phases of medical waste management is the segregation phase, and these are some really good examples with some amazing outcomes. It is essential that we do move away from a linear economy to a more circular economy that minimises the negative impacts of waste on the planet and promotes sustainable development. A shout out to my very talented 15-year-old Noah, who created this image for us today. That's what you get for having a sick day at home. You have to put in some work for me. This slideshow shows us what our current system looks like. So this idea that we take, make and dispose. Opportunities where we could be recycling, recognising that we don't need more recycling, we actually need less waste. And in health, a large portion of these emissions are generated from the manufacturing and procurement of medical supplies and pharmaceuticals, most of which are disposable. In circular economy, products, materials and resources are kept in use for as long as possible. So we really need to start designing out non-recyclable, non-biodegradable, high emissions waste from entering the system at all. Lastly, a good friend recently said to me, you know, when you find a problem, that's where we need to fund it and fix it. Find it, fund it and fix it. And I certainly want to take part in fixing the problem. And this conversation today highlights a very pressing issue that we all need to take part in fixing for current and future generations. Thank you, and I'll hand over to the Women's and Children's team now.
Thanks so much, Sarah. So I'm Chris Barber, and I lead the environmental stewardship group here at the Women's and Children's. First off, I would just on behalf of Kirstine and myself also acknowledge the land that we're meeting on today is the traditional lands of the Kaurna people. The Women's and Children's offers statewide services, and so we reach all lands across all of South Australia. So we acknowledge anybody who might be joining from the Women's and Children's at one of our regional sites. Also wanted to say as well that the Environmental Stewardship Committee also acknowledges that First Nations people, in particular the Aboriginal people in Australia, are the very first natural resource managers of lands, and we know that they have a lot of knowledge to pass on to us. So Sarah's given a bit of an overview of what waste is, and Kimberly a couple of sessions ago gave a global perspective, and I just want to remind us of some of those facts. So the Lancet said climate change is the threat to human well-being and planetary health, and Australia's climate has warmed about 1.5 degrees since around 1950, which is the Industrial Revolution. Australian health services contribute about 7% of total carbon emissions, and that TCO2E little item it's not just carbon dioxide, it's any greenhouse gases, and it's that particular formula is combined so that when there's global measurements, there's we're all working from the same denominator. So that includes the methane that Sarah mentioned recently. So when you see that, you'll understand it is every kind of greenhouse gas. What we need to put in context, though, is if health services in Australia create 7% of Australia's emissions, when you consider that South Australia is about 7% of the population, South Australia in total produces 7% of Australia's total emissions. So the whole of, this is a bit complicated, but the whole of Australia's health emissions are equal to everything that South Australia produces. It's not a small number. It might sound small, but it's not. Increased media and government attention on climate change has brought about a number of things. People are talking about it. That's great. The conversations are happening, but it isn't always being linked to human health outcomes. And there is evidence that in the literature of climate anxiety in young adults, and so it's not just immediate climate effects. It's got a knock-on longer term. So what's the South Australian context? Well, South Australia is responding to climate change across 3 pillars. One of them is renewable energy, and fortunately South Australia is almost 100% renewable with electricity. They're looking at emissions reductions and then climate resilience, which is how we respond to it. So what we need to consider is what are we doing about it? And the areas in which health are responding is, particularly public health, is reducing the emissions from government operations and managing the climate risk with our government operations. And I'll just explain that a little bit more. So I want to make a clear distinction between what sustainability is and what waste management is. And waste management is, as Sarah has explained and used the photos from theatres to show, it's how we look after the stuff that's left over from whatever our operations are, and whether it goes to landfill or recycling or alternate fuel sources like firing up the Adelaide Brighton cement kilns. But sustainability is actually not creating that waste in the first place. And the waste is globally given one of 3 categories. Scope 1 is what the waste is from our operations, and that's sort of the stuff that Sarah was explaining. Emissions, which is the use of electricity. Fortunately, again, as I say, in South Australia, we are almost 100% renewable, but at this hospital, I'll explain a bit later, we also use gas to generate electricity. The biggest use of resources in a hospital is air conditioning and maintaining environment. So that's a really big one for Scope 2. But Scope 3 is our indirect emissions. And this is where, as a local health network, we have less control over because this is our procurement. So we have a statewide procurement process. And so this is at a state level where we need to lobby and work with the procurement teams to get our contracts and our supply chains greener. And they are doing that work too. So what's the Women's and Children's doing? Well, since 2021, we've had the Environmental Stewardship Committee, and the purpose of the committee is to provide governance and oversight of our sustainability activities, and the committee's got an executive sponsorship from Phil Robinson, who's the ED of Corporate Services. I coordinate it. We have 8 clinical champions, including Kirstine. We've got a consumer representative. Our Downer contract manager is part of the team as well, because they are essential in this conversation, as well as BME. We have someone from the department on, as well as the New Women's and Children's Project. And we also have recently been fortunate enough to secure an Aboriginal staff member who was also giving us guidance with their knowledge. So what's come out of that? Our governance is now supported by a sustainability framework, which we published last year. This outlines what our goals are, what we're planning to achieve, and what we can and can't achieve. And one element of that framework is our annual reporting. And so we've just released the 2023 sustainability report, which details all of the activities across the network that occurred last year and what we're planning to do this year. Those documents are available on our website, so if anybody wants to go do a Google, you should be able to find them. So reducing carbon emissions, and I have a rider on that. We don't have an independent environmental audit. We have some. We're using the information we get from our billing and a number of other metrics. But what is the kind of good news is, as we are trying to struggle through without, probably gold standard metrics, what we have been able to ascertain is that in 2011-2012, we had around 14,000 tonnes of emissions. And by 22-23 financial year, we'd reduced that to 9,000. So that was a 34% decrease. So that was great news. A lot of that is due to the fact that we have renewable electricity in South Australia, plus we've done some other things which I will speak about further. So what else can we do? We have this great relationship with Downer, as I mentioned. We're in ongoing conversations with Remondis around our waste data to get consistent data so we can actually compare one period to the next period. We also, just as an aside, talking about alternate fuel sources, during COVID, we set up some collection bins at our 3 entrances and collected patient and staff visitor masks, not things that were used on the clinical side, and they went off to an alternate fuel source, and they also contributed to us not sending more waste to landfill. Christine will talk about the Rogerson Theatres Recycling Working Group, because that's quite a powerful group within the hospital. We have ongoing communications to staff about the correct waste streams, because sometimes, as you know, looking at all the pictures, it can be like an IQ test of where do I put something. So we're trying to remind people, because they're busy, they don't have time to just constantly be thinking about it. We're trying to make it second nature. We also recycle copper and high-grade PVC and battery and printer cartridge recycling. And none of these things are new, but they and lots of other places do these too, but it all contributes to things not going to landfill. What that's resulted in is a 50% reduction in our waste going to landfill in the last 12 to 18 months. So we're really pleased with that. So in not creating waste, one of the things that we've been really proud of is the use of technology. So as many of you would know, we've got the Child and Adolescent Virtual Urgent Care Service that sees thousands of patients a year who do not have to travel to the hospital. So there's a number of things around hospital demand, which obviously is satisfied with a virtual care service. But what it does is it prevents people coming in. When people are seen within a clinical area, that area then needs to be cleaned. A virtual service prevents the use of all of that. What we can't measure is whether or not they've been sent to perhaps a community pharmacy to get a prescription filled or something like that. However, there is a definite reduction. In their first sort of 18 months to 2 years of the operation of Kavooks, just using postcodes, there was a bit of a mud map calculation done that we'd saved 4 trips to the moon and back in mileage. So that's fantastic. We also now have the Women's and Children's at Home. So a nurse will visit in a prescribed area within 40 kilometres of the CBD. That prevents all of those families coming in. It's one as neat as you can get, shortest travel route. So that is also reducing the carbon emissions of treating those families. We've just established the virtual women's assessment service. That's a service which for women who are less than 20 weeks gestation, and those women can then call up and say something's not quite right. It prevents them coming in and hopefully an early intervention to support them in their pregnancy. The evidence in the literature suggests that any implementation of an electronic medical record also reduces the carbon footprint of a service. And we've just had our 1-year anniversary of having Sunrise EMR. And we have also just implemented the enterprise service of electronic referrals. And that has saved, just in that one thing, 1,250 odd pieces of paper a week. So all of the technology is assisting. In terms of our infrastructure, we ceased the use of desflurane anaesthetic gas about 18 months ago, and I'll speak about that in a sec. Also stopping nitrous oxide leaks and investigating scavenge systems. When a woman is using nitrous oxide during labour, her next 7 breaths are still exhaling nitrous oxide. So it's a difficulty for the environment, but also a safety issue for the staff who are assisting her. We're trying to get the last bit of funding required to decommission our gas cogenerators. We need to buy some chillers for our refrigerated air conditioning, and then all of our air conditioning will run on renewable energy. As with government policy, we are transitioning all of our fleets to EVs and hybrid vehicles. So again, that Women's and Children's at Home will almost be carbon neutral because they're going out in EVs. All of our facilities, including our leased premises, have been changed over to LED lighting or in the process of, which is a really big thing when we've got shared premises with education and other services where we co-locate. Our women's and babies area is also looking at increasing the use of reusable baby bottles versus disposable. So you can imagine a birthing hospital, we've got a lot of baby bottles happening. But one of our rate limiting steps with that was how we could turn over quickly enough the reusable bottles. So they're investigating a new dishwasher specifically that will take on a sterilisation cycle as well. All of our, and again, a lot of this won't be news to anybody, but cellulose fibre cups and takeaway containers are now standard in our cafes. So we're not contributing to landfill there. And again, sorting the theatre waste and incinerated medical waste, which Christine will speak to. So just this story with desflurane, there's an equivalent anaesthetic gas, sevflurane, clinically equal. We were the first hospital to remove that. And this graphic, which comes from the College of Anaesthetists, shows that 1 hour of use of desflurane in surgery is equivalent to driving 200 to 400 kilometres, obviously depending on your engine size, whereas 1 hour of sevflurane is driving equivalent to driving 5 to 10 kilometres. So there's a huge difference, and that's why we made that change. Also with our other opportunities, so the decommissioning of the gas cogenerators, the increased use of electrical consumption from the grid, which is renewable, and then reducing losses of nitrous oxide either through scavenge systems or leakage. The combined actions of those will result in another 30% reduction in our carbon emissions. So for a hospital that has ageing infrastructure and a number of other difficulties, in some respects, we're trying to punch above our weight. So what else are we doing? We're engaging with our consumers, and particularly the Youth Advisory Group, who are an amazing bunch of young people. They are from face-to-face workshop with a bunch of other members who are from our regions, and the list of things that we got from them, which were really quite useful. Some things have been done elsewhere and we're trying to get them implemented here, but they were very energetic and a great bunch of people to give us advice. I participate in national and local forums, and I also sit on the Climate and Health Alliance group that Sarah was speaking of and where she is now located, and also the local forums at the state level. What are our barriers to success? Our ageing infrastructure. We can't cover the roof of our hospital in solar panels because we would then need to completely redo all of the electrics across the hospital. Given we've got a new hospital coming, the cost-benefit analysis just doesn't stack up. We have a limited hospital footprint, so that means all of those sorting bins require a space, and we don't always have that space, and we have at times congested corridors because we're trying to fit bins in areas. The other difficulties as well, you know, trying to collect food waste and things like that. We don't have space in tea rooms, so there's quite a difficulty with that. We have 3 linen deliveries a day because we can't stock 24 hours worth of linen. So the use of reusable gowns and things like that is a real challenge, but we are investigating it. Our new hospital's due in around 2030. So again, as I say, there's a reduced appetite to invest in this current site. And the other thing is that we don't have a dedicated resource for sustainability. So this is one part of my job. It's one part of Kirstine's job. And so we're sort of trying to keep a number of balls in the air. So that's enough from me, and I'll now switch over to Kirstine.
Okay, so looking at the Rogerson operating theatres, we have been doing different initiatives over the years, and we're trying to branch out now to the rest of surgical services, and there are other areas in the Women's and Children's Hospital that are doing things piecemeal, and it's gradually building, so we're getting that domino effect occurring. So currently things we do is for all our electrosurgery equipment that is mostly single use, or even the reusable things that get condemned, we send the wire components off for copper recycling, and we obviously get a financial incentive for doing that. We already recycle our PVC, so that's our IV bags and some portions of the line. We recycle our batteries, our paper and cardboard, and our huck towels. So our huck towels inside of our sterile gowns are a material which we get sent off and re-laundered, and then they get sent off to be used as rags within Australia and also overseas. And like Chris mentioned before, we also recycle the printer cartridges, the aluminium that we have from a variety of different sources. And then we also obviously recycle cans that people are, like drink cans that people are using, and we use that money and send it to the Women's and Children's Friends organisation. So some other initiatives we are doing is those things that both Sarah and Chris have spoken about, is we're trying to redirect our landfill and what we can, what we can send off for dry waste, we do. So as Chris mentioned before, we are limited with our footprint, so we don't have the ability to recycle in the variety of streams. So we try and condense it into dry waste. So anything like from a little vial of saline that's obviously empty to our KimGuard wrapping that we use for our reprocessed medical devices, to all our soft plastics, hard plastics, even metal, our instruments go into this dry waste and can be recycled, or not recycled, repurposed. And as Chris has also mentioned, we have changed over our desflurane to the sevoflurane and the nitrous oxide with scavenging and so forth. And things like the rest of the hospital, we have obviously mattresses that have to be rotated for infection and for pressure area care. So some of these actually get sent overseas. As you can see this picture here, there's a shipping container that our Downer counterparts have organised to have this sent overseas, and then they reuse it in their facilities as well as other furniture. So how do we make this happen? We've got great partnerships with Downer and other third-party services. And I've also got some fantastic people on my recycling working committee, and they have done things like this sustainability board here. It's very interactive and very visual, so people can actually see, right, I know that this actually needs to go into this bin and this needs to go into that bin. So it makes it a lot easier rather than doing flowcharts in like a paper format. And obviously the appropriate signage and communication. So in our meetings, or even in like our little champions can within the theatre and ward environment can tell people, right, no, you can't put that in this bin. It needs to go in this bin because this is what the result is if you put it in this bin. So they have been fantastic and have also been mentioned in our Wednesday wrap newsletter for their great work that they do. And obviously having the appropriate vessels for the different waste streams so you can identify what rubbish or what byproduct goes into which bin. Some of the barriers we've had is obviously finding the appropriate vessel to put the products into, and I have tried a variety of bins, and I haven't found the perfect bin yet. But anyway, so finding the appropriate bin and also the actual liner that we use to identify it. So here you can see we've got bins with a clear bin liner and bins with a black bin liner. So the bins with the black bin liner go to our general waste, and our bins with our clear liner go to our dry waste. So it's quite easily identifiable for our theatre orderlies to put it into that maroon bin for the dry waste or the red bin for the general waste, and same with the downer when they get it at the other end. And obviously having appropriate signage can be a bit of a barrier, so they might be a bit confusing for them, and also laziness. And another barrier is cost for us. So here, obviously, our footprint, we don't have the space for another compactors for our dry waste. So we have got, outside of our hospital executive building, a number of dry waste wheelie bins that get filled up on a daily basis, and then they get emptied on a daily basis by Remondis. Otherwise, if we had a compactus, that could all be condensed and only be emptied every couple of days versus daily, and which would be less of a cost pressure for the Women's and Children's Health Network. Some of the successes that we've had is obviously our recycling committee has branched out to the surgical wards, our outpatients, our dental department and our surgical admin area, as well as the perioperative space. So that has been fantastic, and having engaged staff, and that's not just nursing. We've also got medicos on board, as well as our theatre orderlies and our CSD staff on board as well. As I mentioned, we've been recognised for our good practices in our local newsletter, and more areas, like I mentioned earlier, are adopting our practice. So South Australian Medical Imaging here at the Women's and Children's have branched out, our Rose Ward, our Cassia Ward. So they're slowly doing bits and pieces around the hospital to reduce this landfill. So at the moment, we're at 50%. We're reducing sending it off to landfill, but we can get better with our current practices. It's not the best practice, like Sarah mentioned and Chris mentioned. It does start at the beginning of where the product comes from and what they do, but we're trying to reduce the impact for the Women's and Children's. Another success story that we have that I haven't put on the slide, and we're just waiting for our company to support or have the stock to support this, is we've done a trial with Ansell, and for our surgical sterile gloves, we're getting a glove-in-glove product. So instead of using 2 packets of gloves that have got 2 plastic outer wrappers, a paper inner wrapper, and then the gloves inside. It'll have the glove inside the glove, so double gloving would be hopefully more compliant for our staff. And we will only have one wrapper, one external wrapper, one internal wrapper, which will reduce our waste at the end as well. So that's something for us to look forward to once the stock is available from Ansell. And that's all I have to say. So thank you.